Dr. Spriya, Sarve Bhavantu Sukhina, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kaschit Dukh Bhag Bhave, Na Toham Kamaye Rajyam, Na Swarga Na Punarbhavam, Maye Dukkha Taptanam, Prani Nam Aati Nashnam.
So, good morning everyone. A warm welcome to the 6th CME, and that is a topic which is a cause of concern for patients, parents, and can significantly affect the well-being of young children. The topic is the approach and management of constipation in children. Constipation is a common yet challenging condition, especially in the pediatric population, where identifying the causes and implementing effective management can prevent long-term issues. As healthcare professionals, understanding the intricacies of this condition and learning how to handle it with the best evidence-based practices is essential to providing comprehensive care. And to guide us through the important subjects, we have with us a highly respected expert in pediatric surgery, Dr. Manish Kumar Gupta. And I would like to introduce him. Dr. Gupta is a highly skilled pediatric surgeon and consultant and the director of Medical Hospital Gorakhpur. He has a distinguished educational background, having completed his MBBS from FMC Pune, followed by his MS from Odisha, and he specialized in pediatric surgery with an M.ch from CMC Vellore. After completing his M.ch, Dr. Gupta pursued a fellowship in pediatric gastrointestinal surgery from SHAI Lucknow. His academic career includes a significant stint at AIIMS Rishikesh, where he served as an assistant professor and later as associate professor, contributing to the institution for 5 years. Presently, he is heading Miracle Hospital in Gorakhpur. Dr. Gupta's clinical interests span pediatric urology, neonatal surgery, pediatric thoracic surgery, and pediatric gastrointestinal surgery. And we are honored to have Dr. Gupta with us today, and I invite him to enlighten us on this managing constipation in children. Please join me in welcoming Dr. Gupta.
For the topic approach and management of constipation in children. Coming to the introduction of the topic, the constipation is a common problem in children and it accounts for about 3% visits to the general pediatric clinics. Out of the different causes of constipation, functional constipation is the commonest type, and it is commonest throughout the world. There is a general perception that in South Asia the food is rich in fibers, so the children may not be having the functional constipation, but because of this, many of the children are put up to the diagnosis of Hirschsprung disease instead of diagnosing further for the functional constipation. Before coming to the topic, I would like to go for the stool pattern in the normal infants. The median stool frequency at 1 month of age is about 3, ranging from 0 to 9 per day. And at 3 months, it is reduced to 2, 0 to 6 per day. There is a significant difference in stool frequency between the breastfed and the formula-fed babies. At 1 month of age, it is 4 versus 1, and at 3 months of age, it is 2 versus 1. The definition of constipation is based on the Rome 4 criteria, and it differs for children less than 4 years and more than 4 years. There is an overlap in the two age groups, and it must fulfill 2 criteria at least once per week for a minimum of 1 month. Here, 2 or fewer defecations per week, history of excessive stool retention, history of painful or hard bowel movements, history of large diameter stools, presence of large fecal mass in rectum, and in toilet trained children who are more than around 2 years of age, there are additional criteria with at least 1 episode per week of fecal incontinence after acquisition of toilet skills. History of large diameter stools that can obstruct the toilet is also one of them. The same thing is carried forward to the children in more than 4 years, and most of the points are repeated here. Coming to the etiology and prevalence, constipation is quite common in India. It is commonly seen in toddlers and preschool children. In 17 to 40% of cases, constipation starts in the very first year of life. 95% of the cases are due to functional reasons, while 5% cases are due to some organic causes. Among the organic causes, the Hirschsprung disease is the commonest and is one of the most important cause. So coming to the causes of constipation in children, first is the functional constipation. Second is motility related disorders like Hirschsprung disease, myopathies, and intestinal neuronal dysplasia. Then congenital anomalies like anal stenosis, anteriorly placed anus, or spina bifida. Neurological causes include cerebral palsy, mental retardation. Endocrine and metabolic causes include hypothyroidism, renal tubular acidosis, diabetes insipidus, and hypercalcemia. There are some drugs which cause constipation that are anticonvulsants, antipsychotics, and codeine related antidiarrheals. So how does the constipation start? There is an inciting event where the child has a change in routine or change in diet, or there is any stressful event, or there can be a postponing defecation when the child might be traveling or something, or if the child is vigorously trained in the toilet training at early life. So in that point, the defecation is painful, and that pain brings out fear in the child. So the child goes for voluntary withholding of the passage of stool. Once that withholding of passage of stool is there, due to fecal stasis, more amount of fluid is reabsorbed from the stool, and it becomes hard in consistency, and the size also grows. Once the hard stool and more bigger size has to be passed, the child will feel more pain and will further try to withhold. So this becomes a vicious cycle of voluntary holding, then stasis, pain, and passage of painful stool. These children develop stool holding maneuver or retentive posture, which parents erroneously think that there is an attempt to defecate. Actually, the child is trying to stop the stool, passage of stool, rather than passing the stool. The child will hide, the child will strain, the child may even cry and make sounds. Liquid stool from the proximal colon may percolate around hard retained stool and pass per rectum involuntarily, and may cause swelling of the pants, and this is called fecal incontinence. Then once the stool becomes large, gradually the size of the rectum will also grow in the size to adapt it, and the rectum will become dilated and redundant. Once that happens, the sensitivity of the defecation reflex and effectiveness of the peristalsis become reduced, and rectal action is reduced, so passage of stool becomes difficult. There is difference between functional constipation and Hirschsprung disease. The features are the features which differentiate the functional constipation and Hirschsprung disease include the things which are starting at the time of birth. In functional constipation, at the time of birth everything is all right, but delayed passage of meconium is seen in the Hirschsprung disease. So onset of Hirschsprung disease is at the time of birth, while the onset of functional constipation is close to 2 years of life. Fecal incontinence will be very rare in cases of Hirschsprung disease, and it is common in functional constipation. History of fissure and painful defecation will be there in functional constipation, and it is rare in Hirschsprung disease. The failure to thrive is uncommon in functional constipation, and it is possible in Hirschsprung disease. Enterocolitis, especially the Clostridium difficile enterocolitis, is seen in cases of Hirschsprung disease, and it is not seen in the functional constipation. Abdominal distension will be present in Hirschsprung disease, and it is usually absent in the functional constipation. The most important thing in the physical examination is rectal examination. In rectal examination, because the distal part of the rectum is constricted, so rectum will be empty, while in functional constipation it will be loaded with stool. There will be malnutrition in Hirschsprung disease, and in functional constipation it will be absent. So this is two barium enemas which you can see. This is the anal verge, and from here you can see that there is diffuse dilatation of the rectum, while here from the anal verge the constriction is there, and this is the transition zone, and beyond this there is dilatation. So in this constricted portion the ganglion cells are not present, so this is Hirschsprung disease, while in this case the ganglion cells are present throughout and it is dilated, so this is more towards the functional constipation. Coming to the assessment of the child with constipation, a careful history and physical examination is must, and it is important to rule out organic causes. First we start from the onset of disease, and we see that fever, vomiting, bloody diarrhea or failure to thrive is present or not. If these things are present, then it goes more in favor of organic causes than functional constipation. During the physical examination, anal stenosis, tight empty rectum, lack of lumbosacral curve, flat buttocks, sacral agenesis, anteriorly displaced anus and gush sign of air is seen in cases of organic constipation. Usually whenever we get any patient of constipation, we subject them to contrast enemas, but this is not required in all the cases. We can go with the physical examination, and distal rectal examination is quite good enough to tell whether it is functional constipation or a organic cause. In barium enemas, like in Hirschsprung disease, it is said that the contrast will be retained beyond 24 hours, so that thing also happens in the functional constipation. Coming to the management, so in this we have to determine whether there is fecal impaction, because the loaded colon will be having hard stools and that will gradually pile up, so it will cause fecal impaction. So treatment of this fecal impaction is the first thing which has to be done. Once the fecal impaction is cleared out, then we have to initiate the maintenance treatment with oral laxatives, dietary modification and toilet training. Once the habit becomes normal, then we need to go for the close follow-up and medication adjustment as required. So in disimpaction, so how will we know that there is fecal impaction? That is best assessed by abdominal examination with the palpation of hard balls of stool or distal rectal examination. If that is present, There are two methods, either by oral route or by rectal approach. Oral approach is non-invasive. It gives a sense of power to the child. The child will not have fear and will accept it easily. But the compliance is a problem, like how much to be given, the parents will give or not, all these things will come into play. Then polyethylene glycol lavage solution is usually given, and it is the best thing to go for disinfection of stools. In rectal approach, enemas, proctoclysis enemas are faster but invasive, and that will again bring fear to the child who is already feared. So that is done when the compliance is weak, and usually the second option over the oral route. Once the disinfection is done, maintenance therapy starts. It comes with dietary modification. Diet of most children with functional constipation lack fibers, and in our Indian system we see that the mothers keep on giving milk beyond 6 months, 9 months. So the main food is almost constituted of milk and very less amount of complementary foods. That also causes constipation. And we need to know here that cow milk protein allergy is also one of the major thing which plays a role in the constipation. The child should be encouraged to take more fluid, absorbable and non-absorbable carbohydrates as a method of softening the stool. And then apple juices, pear and prune juices, they have sorbitol, which loosen the stool. A balanced diet that includes whole grain, fruit and vegetable is advised, and milk and dairy products are restricted. Toilet training also becomes a part when the child is near about 2 years of age. The child is encouraged to sit in toilet for 5 to 10 minutes, 3 to 4 times in a day. Usually the time is fixed so that the child may get primed, and it usually is done after major meals for initial month, because after major meal the child will be developing getting the gastrocolic reflex, and it will be easy for the child to pass the stool. One more thing is important, that the posture of the child while passing the stool. Some people say that the child is standing and passing the stool. That is not the correct posture. The child should be sitting in a potty seat with the legs flexed at hip and knee joint, and the legs should be supported either on a stool or on the ground. Maintenance therapy includes laxative. Lactulose is considered one of the good laxatives, but after coming up of the PEG has become taken over the lactulose. In many RCT, low dose polyethylene glycol is found to be better tolerated than any other laxative, and with long term use, lactulose usually lose the efficacy because of change in the gut flora, which PEG does not does. The dose of laxative should be adjusted to have 1 or 2 soft stools per day without any pain or soiling. Once this target is achieved, the same dose should be continued for at least 3 months to help the distended bowel to regain its function and caliber. Laxative needs to be continued for several months and sometimes years at the right dose. So the therapy is actually lasting for years, maybe months to years. It's not for days. Close follow-up is necessary. Initial follow-up should be monthly till regular bowel movements are achieved. After that, it should be 3 monthly for 2 years and then yearly. Once the regular bowel habit is established, the laxative dosage can be decreased and gradually stopped. Now coming to the one of the surgical aspects in the functional constipation, that is failure of medical management. Once the medical management is failed, then the child is subjected to surgery. Surgical options are brought here, but there is no clear-cut definition of when the medical management has failed. So the surgeon will be receiving cases of constipation at different stages. Surgery is required in these cases with following indication: ongoing constipation with failed medical management, if the fecal incontinence is present, and presence of anatomic megarectum. Surgery is offered only after the child has undergone long intensive bowel management program along with training and education of the caregivers. So at least 2 weeks of intensive bowel management program has to undergo before planning for surgical management. So every patient who has failed medical management needs the following. First is contrast enema to evaluate morphology of colon. In contrast enema, we can find dilated segments of colon, the redundancy, strictures or transition zone. So here in the first picture, you can see that the rectum, though it is normal in caliber, but the anatomy is not very clear, the haustrations are not clear, and it is tortuous. And in the second one, you can see the rectum is hugely dilated. Then evaluation of anal sphincters with anal manometry has to be done. So in this we see for the rectoanal inhibitory reflex, probes are placed in the sphincter region and a balloon is placed in the rectum. The balloon is gradually inflated and the pressure of the rectum is increased, and we see the response of this increase in the pressure in the rectum over the sphincteric pressure. Usually the physiology is, once the rectal pressure is increased, the sphincters will relax and the pressure in the sphincter region will decrease. So once you can see here the pressure in the rectum is increased, so once it is increased, the pressure in the sphincteric region will decrease. But in cases where the organic cause are present like Hirschsprung disease, this will be absent. So absence of rectoanal inhibitory reflex is seen in cases of Hirschsprung disease, and if that scenario is present, then we will have to confirm the thing by taking rectal biopsies. And second thing, in a rectal biopsy, it can be presence or absence of ganglion cells. If the ganglion cells are present, then it is the sphincter problem, not the rectal problem. So in that case, the sphincters has to be managed with botulinum toxin if the internal sphincters are involved. If the external sphincters are involved, then biofeedback mechanisms and therapies are to be tried. If the ganglion cells are lacking, in that case management according to the Hirschsprung disease has to be done. Then there is another thing, pelvic dyssynergia, where the external sphincter or the pelvic floor muscles are too tight and fail to relax. The patient will need again this biofeedback therapy and botulinum injection in these cases. One more thing is the posture. The sitting posture will also relax the pelvic floor muscles, and that's why it is preferred to make the child sit and pass the stool. Then for the other part of the colon, colonic motility studies are tried, and we see that whether the motility of the colon is normal or not in different segments. So here we give capsules with different size of radio markers, and that is given over 2 to 3 days, and its distribution in the colon is seen. So the pattern can be normal, or segmental involvement can be there, or diffuse involvement can be there. So in this image you can see the markers are diffusely placed throughout the colon. So it is a diffuse involvement, and in this case extensive management of the colon has to be done. While in the second case you can see the markers are limited to the rectum and sigmoid. So a segmental management has to be done. So there are different surgical options which we can provide in these difficult cases. The cases where failure to thrive is there and diffuse dysmotility is present, we go for ileostomy or a procedure called as MACE, that is Malone's antegrade colonic enemas. And then if the anal sphincter problem is present, Botox injection and biofeedback therapy is required. If anal manometry is normal and colonic manometry is also normal, then in that case antegrade options like MACE has to be tried. If antegrade manometry is normal and colonic manometry is abnormal, that means there is involvement of the colon rather than the sphincter, in those cases, like if the segmental is involved, then segmental resection with antegrade option has to be tried, and if the diffuse involvement is there, then antegrade option with diffuse resection has to be seen. Sometimes in these cases of constipation, the stool which is held up in the rectum will put pressure on the bladder, urinary bladder, and in that case there can be a chance of development of non-neurogenic neurogenic bladder. That means if the stool is putting pressure on the bladder outlet, the child will go into retention, or if there is pressure on the body of the bladder, then the total capacity of the bladder will get reduced. So the child will present with frequency. Sacral nerve stimulation is tried, where we promote the defecation reflex. So this is the Malone's antegrade colonic enema method. Here the appendix is wrapped around wrapped inside the dilated cecum and is brought out at the umbilicus. So you cannot see even the opening of the this appendix. So appendicostomy has to be done, and through that a tube is passed and enemas are given. So that will flush out all the retained stool, and the child can be managed with this. So whole of the colon will gradually become normal in caliber, and once it is normal, then we can subject the child to laxatives and other things. If there is a lot of redundancy, huge dilatation, then in that cases the motility of this part will be very less. So in those cases we usually go for the M.ch procedure and we resect out the abnormal dilated part and we do the primary anastomosis of the normal caliber part to the distal rectum. There are certain areas of controversy. One is the use of this pharmacological agents, probiotics. So probiotics have no effective role in cases of functional constipation. It has not been shown with any evidence. Then polyethylene glycol is seen to be having some side effects which has been reported in form of tremors, tics and obsessive compulsive behavior in children. But this is not very grave, so FDA has not taken any necessary action on this. It is said that while preparation of PEG, there are certain other thing which is traces amount of ethylene glycol, diethylene glycol or triethylene glycol is present, which can be neurotoxic and that can contribute to this thing. Some novel pharmacological therapies have come like lubiprostone, which increase the chloride rich fluid and soften the stool and enhance the stool volume and cause better defecation, and prucalopride, which is enhancing the motility of the gastrointestinal tract, but they are still under trials. Then in cases, as I have already told, in urological involvement, sacral nerve stimulation is used for creating the defecation reflex, and it has shown better management in those cases. So this is all about the constipation.
I request Dr. Anju Jain ma'am to please come forward. Question 1 is, a child with functional constipation has undergone disinfection therapy and now has started on maintenance therapy. What would be the first therapy child can be offered?
हाथ उठाइए.
हाथ उठाना है.
डॉक्टर साहब, डॉक्टर पांडे.
Normal fiber, low dose laxative and toilet training. Is that right answer?
Yes, sir.
That's the right answer. A big
Correct
applause for
answer.
Dr. Pandey sir. That's the right answer.
Next.
So, question 2, the optimum time a child should sit on the potty seat when doing toilet. Raise your hand.
आप बताइए फर्स्ट.
Dr. Omkar?
या
Yeah, Dr. Omkar. Big round of applause. 10 minutes is the right answer. A 3-year-old boy was referred to a pediatric surgeon with complaints of frequent constipation. Mother told that every time she used to give laxative for 15 days during which child used to pass stool nicely, but as soon as she stopped the laxative, the child will not pass stools and will develop abdominal pain. This has continued for more than a year now. What should be the best option surgeon should provide the mother? Laxatives, mace with sigmoid resection or Botox and biofeedback therapy? We'll take the answer. We'll take the answer from here.
डॉक्टर अश्विन यहाँ पर.
Mace with sigmoid resection.
नहीं अब आपका 3 हो गया. और कोई? नहीं आप बताइए.
Dr. Singh.
कौन सा आंसर है?
इसी तरफ से होगा.
So, Dr. Vivek Gupta sir.
Gupta sir.
Laxative is the right answer. Big applause for Dr. Vivek Gupta sir. Okay.
आपके साइड में आ रहा है.
So, quiz question 4. Absence of prayer means when rectal pressure increases, sphincter pressure increases, and so on. You can choose any one of the right answer.
IR means.
Sir, you have raised your hand.
डॉक्टर प्रतिभा गुप्ता.
When rectal pressure increases, sphincter pressure increases. That's the right answer. Big applause for Dr. प्रतिभा Gupta ma'am. So question 5, we'll take the answer from this side. A boy of 2 years was having chronic constipation and underwent contrast enema. Which of the following feature will suggest that there was an organic cause of constipation? Raise your hand.
हाँ बताइए कोई nobody
अच्छा इधर से हो गया इधर से है ना
हाँ किधर से इससे पूछे कोई हाथ नहीं कर रहा है
No problem. Just exchange of the year also, please. I think this.
हाँ डॉक्टर वीर गुप्ता ही बता रहे हैं वापस
The diameter of rectum was less than diameter of sigmoid colon?
Yes.
Yeah, that's
Very
right.
nice.
very nice
The timing of school timings means, but I feel that school timings are more responsible for functional constipation nowadays.
Lights on.
Let's
go on control.
Like nursery or up to class 5th.
Yes, sir, that is there. Actually, whenever the child is started for school going, at that time the whole of the time slot for the child changes. So it becomes a kind of a stressful thing. Plus, it becomes odd for the child also. So usually we can fix some time once the child is going to school. Like before going to school, we fix a time when the child is getting up, and after that we ask the child to go for passing stool. And in the evening also, we can fix a time and ask the child to go for passing stool.
There are 2-3 problems which I think which we should recommend to the school management. Number one, timing should be rather not around 7, because what is happening in practice, the child is has to get awakened around about 5:30 or like that when he is in sleep, and around 6 he has to take his bus and one hour round up of the city, and then he reaches to the school. In that case, there is functional constipation and there is also failure to thrive, because he is not taking his meals properly. These two things are going.
So for that, sir, the management of the school and administration of the school has to be.
Recommend the school to change the timing of smaller classes.
So usually I have been in Uttarakhand, and usually the school timing for kids up to class first is at around 9 o'clock. So they reach school by 9 o'clock and they get up at around 7
9
o'clock.
or 10 is okay, but it's 7.
यहाँ तो नहीं है
पता चले 6 बजे बस
सोने का टाइम बदल गया। प्रॉब्लम की जड़ वहाँ है। पेरेंट्स जो हैं सीरियल देखते हैं, बच्चों को भी जगाए रखते हैं, तो सुबह उठने में दिक्कत होती है, इसलिए सारी प्रॉब्लम की जड़ है। अगर हम 9 बजे टाइमिंग कर देंगे तो जो बस को आधी घंटा लग रहा है स्कूल पहुंचने में, शायद 1.5 से 2 घंटा लगने लगेगा बस को स्कूल पहुंचने में, तो दूसरी प्रॉब्लम शुरू हो जाएगी। तो एक प्रॉब्लम के चक्कर में दूसरी प्रॉब्लम, हर चीज का एक सिंपल सोल्यूशन नहीं होता है। बेस्ट तरीका यही है कि अगर जिनके पेरेंट्स को जल्दी स्कूल भेजना है बच्चे को, वो जल्दी सोना सीखे और जल्दी उठना सीखे, बच्चे को अच्छे संस्कार देंगे, ठीक रहेगा।
फेसबुक और इंस्टाग्राम बंद कर दें
मेरा ये कहना, मेरी ओपिनियन ये है, और रिकमेंडेशन ऑफ द अमेरिकन सोसाइटी एंड मे बी द ब्रिटिश सोसाइटी, वहाँ पे ना अमेरिका 9 बजे सो जाता है, इनके बच्चे भी सो जाते हैं, और सुबह वो 5 बजे उठ जाते हैं और सारा ये ट्रेनिंग करके बच्चों को भेजते हैं। तो यहाँ पे अपने हिंदुस्तान में द पेरेंट्स वुड बी रिफॉर्म देमसेल्फ, बस तब वो बच्चे क्लिक कर सकते हैं और बच्चे का अच्छी हैबिट डेवलप कर सकते हैं। मेरा ये ओपिनियन है।
इसमें जैसे इंडियन स्टाइल और वेस्टर्न स्टाइल वो भी है ना, डिफिकेशन का भी, उससे भी काफी डिफरेंस हो गया है। बिकॉज बचपन में जैसे बच्चों को भी आजकल सीधा जो है कपबोर्ड वगैरह ये यूज हो रहा है, अदरवाइज अगर दे शुड use Indian style. क्या इसमें कोई है?
Indian style and Arab style both have same thing, but the thing is the posture. The legs should be resting. The child should be sitting forward rather than sitting.
तो वो तो
like that.
वेस्टर्न में तो ऐसे ही बनेगा।
वो मतलब अगर आप उसको बच्चे को मोबाइल दे देंगे तो वो आराम से बैठेगा। अगर आप उसके साथ
नहीं, इसमें कुछ जो कॉन्स्टिपेशन के लिए योगासन कराए जाते हैं, डॉक्टर विवेक गुप्ता को भी मालूम होगा, हम लोग कराते हैं। उसमें फर्स्ट जो आसन होता है वो ऐसे होता है कि आप इस तरह से बैठ के इंडियन स्टाइल वाले उस पोस्चर में बैठ के और आप नमस्कार करें, या उसमें जो उत्कर्ष मतलब उसका उधर उत्कर्ष आसन उसको बोलते हैं, तो उससे बहुत इजी आपका कॉन्स्टिपेशन रिलीफ होता है। ऐसा
that is very true. Actually, the sitting in the Indian style relaxes the pelvic musculature and pelvic diaphragm very much, and that contributes to easy passage of stool and urine both.
मैं डॉक्टर मनीष गुप्ता को इस एक्सीलेंट लेक्चर के लिए बहुत बहुत धन्यवाद देता हूँ। मेरा भी बहुत फेवरेट टॉपिक है, जैसे उन्होंने कहा है कि बच्चों में बहुत ही कॉमन है, और मॉडर्न लाइफ स्टाइल जो ये पिज़्ज़ा और मैगी और फलाने और माँ के फास्ट फूड में तो सब खाता है, जैसे नाम भी नहीं जानता, लेकिन इसने हैवक क्रिएट कर दिया है। बच्चों का स्वास्थ्य बेहतर होने की बजाय वर्स्ट हो रहा है, और सबसे अधिक हम लोग मिडिल क्लास वाले और अपर क्लास के जितने बच्चे मेरे क्लिनिक में आते हैं वो सब कॉन्स्टिपेटेड होते हैं। हालत ये हो गई है कि बच्चा न्यूमोनिया के लिए भर्ती हो रहा है और एक दो दिन टट्टी नहीं करता क्लिनिक में, तो हम कहते हैं कि भाई ये टट्टी नहीं किया, क्या हो गया? अरे साहब ये ऐसे ही दो तीन दिन फिर करता है, और पेरेंट्स को नॉर्मल मान लिया है। It's a havoc. I can tell you it's a havoc and playing really bad health और से anemia होता क्या जब वो फास्ट फूड खाते हैं और ये सब चीजें खाते हैं और चिप्स, अरे दर्जनों के हिसाब से लोगों ने बताया कि सब हम तो पूरा ग्रूस एक पैकेट लाके घर पे रख दिए। और हॉस्टल में पढ़ने वाले लड़के, हमारे एक मित्र हैं, बड़े आदमी हैं, हॉस्टल में पढ़ने उनकी बेटी दर्जन के हिसाब से मैगी अपने हॉस्टल में मंगाती है। तो हम माँ बाप भी उतने ही जिम्मेदार हैं इन खाद्य चीज इन प्रॉब्लम के लिए। अनीमिया, फेलियर टू थ्राइव, जैसा डॉक्टर ने कहा, एक विशियस सर्किल हो गया है। और टॉयलेट ट्रेनिंग ऐसे से माँ बाप आते हैं कि 4 साल का बच्चा साहब वो तो हकीस बांध देते, उसी से मैं कर लेता और मैं फेंक देता हूँ। अरे यार हद हो गई, स्कूल जाना है, बच्चे को स्कूल जाना, और 4 साल तक आपका बच्चा टॉयलेट ट्रेनिंग है, और ये डॉक्टरों में और पढ़े लिखे लोगों में सबसे अधिक है, उनके पास टाइम नहीं। माँ को भी 8 बजे जाना है, पिता को भी जाना है, किसी के पास टाइम नहीं कि बच्चे के पास 10 मिनट, से डॉक्टर ने बताया कि बैठ के सपोर्ट करे, बच्चे को इंकरेज करे, कहानी सुनाए, बस वो बच्चा बैठता भाग जाता है, मुझे लगा ही नहीं। अरे लगता तो हमें आपको भी नहीं है, 5 मिनट 10 मिनट जैसा कर 10 मिनट से मिनिमल, बच्चा थोड़ा और भी वक्त लगा सकता है। तो मेरा कहने का मतलब है इस समस्या का समाधान है कि हम सब लोग अपने बच्चों को समय देना सीखें, 2 साल के आसपास टॉयलेट ट्रेनिंग करें, और गांठ पकड़ लें कि फास्ट फूड घर में कम से कम ना रखें। बाहर तो भाई ठीक है, मजबूरी समाज को अपन नहीं कर सकते हैं, लेकिन अपने घर में कम से कम फास्ट फूड रखना टोटल बंद करें। आज बच्चे से आप पूछिए, मैं तो मजाक में बच्चों से पूछता हूँ, 5 फल का नाम बता दो, बच्चा 5 फल का नाम बता, 5 सब्जी का नाम बता दो, बच्चा 5 सब्जी का, लेकिन मैगी की सारी वैरायटी का नाम और चॉकलेट की सारी वैरायटी मतलब अपने आप को सुधारें, जैसा किसी ने कमेंट किया है, माँ बाप को सुधारें तो बच्चे अपने आप।
और हमारे बीच एक न्यू फेस है, डॉक्टर वत्सल, डॉक्टर विवेक गुप्ता के सर के बेटे हैं। सो आई वुड लाइक टू इनवाइट हिम एंड आई विल आस्क हिम टू इंट्रोड्यूस हिमसेल्फ।
नमस्ते, मेरा नाम डॉक्टर वत्सल भूषण गुप्ता है, और मैंने 2024 अगस्त के महीने में अपना DM पूरा किया है एम्स पटना से, पल्मोनरी क्रिटिकल केयर और स्लीप मेडिसिन में। उससे पहले मैंने 3 साल अपना MD वल्लभ भाई पटेल चेस्ट इंस्टीट्यूट न्यू दिल्ली से किया था, और FBS UCMS एंड GTB हॉस्पिटल न्यू दिल्ली से ही किया था। और अभी मैं सिटी सुपर स्पेशलिटी हॉस्पिटल में कार्यरत हूँ। वहाँ पे अभी मैंने पल्मो विभाग का काम, जैसे कि मोस्टली बेसिक प्रोसीजर्स जो भी हॉस्पिटल में है ब्रोंकोस्कोपी से रिलेटेड, वो मैंने करना शुरू कर दिया है। धीरे धीरे जैसे जैसे और इंस्ट्रूमेंट्स आएंगे, जो चीज़ मैंने अपने इंस्टीट्यूट में सीखी है मैं उसको और आगे बढ़ाने का प्रयास करूँगा। और अभी तो
ठीक है, वेलकम।